Hi everyone, I'm Dr. Ranjith Ravella, MBBS MD Internal Medicine. So hereby we are starting a series of insecticide poisoning or any other poisonings which we'll be discussing in a series of videos. As I manage most of the poisons at my hospital, so I thought it will be interesting to share some case reports so that whoever is managing these kinds of poisons will have a better idea on how to manage them. So today I'm going to discuss a case of Ethion and Cypermethrin poison and its clinical course and how well it was managed. The insecticide which this patient has consumed was Nagata, which was a Tata product. It contained Ethion around 40%. For the privacy sake of the patient, I kept the name as Mr. Kumar, and he was around 15 years old, male. He lives by near to my hospital at a village called as Sirumari, and the substance he consumed, as we have discussed, is Ethion and Cypermethrin. He has consumed orally around 100 ml of the amount, and at the time since exposure, what they mentioned was approximately 2 hours. So, coming to the clinical presentation and initial management, yeah, he had symptoms such as frothing from mouth and he had increased sweating while coming to the casualty. And coming to vitals, blood pressure was around 190 by 120 millimeters of mercury, pulse rate was 168, saturation was around 85 to 90%. And his temperature was, I mean, the body temperature could not be assessed as he has increased sweating. Pupils were pinpointed, which was strongly supporting organophosphate poisoning. Initially, there was no documentation that any treatment was provided at any other hospital outside. So, coming to the initial management thing, so before admitting him, we have seen his circulation, airway, if the airway was clear or not, and the breathing was assessed. We thought there was increased frothing, so we thought that it is needed to intubate him. So, we need to stabilize him through intubation. So, initially, we had to sedate him and intubate. Then he was admitted to ICU and he was managed for around 10 days. From ICU, he was transferred to the ward for 4 days, and this is how his stay was at the hospital. So coming to the treatment part, which is very important, first thing is I had extubated him on the third day of admission, but it was not ideal. He had to be reintubated on the next day itself because these patients have muscular weakness because of OP compound. So it is always better to wait till the acetylcholinesterase levels are improved, or his sensorium is very much improved, or his neck holding is better. So that was very important in this management, and definitely initially what we have done was the gastric decontamination with the activated charcoal. Though people say that if the patient comes in 1 hour you should do the decontamination, but I have done the gastric decontamination with activated charcoal by mixing it with water and putting it through Riles tube. And second thing was atropine administration was very key, and it is very much important in saving the life of the patient. As soon as you give the atropine, the patient starts improving well. So initially, I have given 1 mg per ml. Then after 5 minutes, I had to see his response. Then increase the dose, doubled every 5 minutes, and ultimately, I had to start him on the infusion of atropine around 5 ml per hour. So he had showed improvement, even though his heart rate was on the higher side. Still, I had to start atropine and give atropine because heart rate was not an indication for the treatment. I took the indication as the frothing. He started to dry up. The secretions or the crepitations have decreased, and his increased. The sweating has stopped, and his pupils were dilated. That was the indication for me to stop that atropine. Otherwise, I had to continue that atropine. To say that his stay was around 14 days, and I had to continue atropine till 12 days. Not in the form of infusion. Infusion was there for initially for around 3 to 4 days. Initially, on the first day, I maintained the heart rate around 110 beats per minute. On the second day, it was around 100 beats per minute, and on the third day, it was around 90 beats per minute. So, coming to the next important thing, Pralidoxime, I had to give Pralidoxime 1 gram 3 times a day, and then taper down to BD and stopped. I think everyone have their own protocol on that, but Pralidoxime is very much important in OP poisoning. Coming to other supportive care treatment, I had to put a prophylactic antibiotic and a PPI and an antiemetic so that he doesn't aspirate the food content or anything which we give. So this was the picture with the patient. So his outcome was good. After 14th day, he was discharged on 14th day. That is from the day of admission. On 8th of January, he was discharged. He was walking well and he was Very good. So this case highlights the importance of early recognition and management of pesticide poisoning. As he has no comorbidities and he is very young, he had a good outcome even though he consumed 100 ml of OP compound. Coming to the synergistic toxic effects of ethion and cypermethrin, ethion, of course, we know it is an organophosphate. It inhibits acetylcholinesterase, so leading to accumulation of acetylcholine. By checking the serum acetylcholinesterase levels, we can assess how much the value it has reduced, and by that also we can decide our management. Coming to second component, it is cypermethrin. It was very minimal. It disrupts sodium channels in nervous system, causing hyperexcitability. So again, management consideration, early recognition. Of course, you should identify the poisoning initial itself and seeing the pupils itself and increased secretions. I understood it's an OP compound, so it is always prompt identification of pesticide poisoning is crucial. Also, see the bottle which they bring and compare both of them are matching or not. Yeah, gastric decontamination is second most important thing. Gastric lavage has to be done. I do it basically for every patients who come to the casualty with consumption within 6 hours. Atropine administration is very crucial in this patient. Atropine, as it is an anticholinergic agent, helps counteract the effects of organophosphate poisoning. Coming to the supportive care, of course, hemodynamic stabilization, respiratory support, and managing seizures with lorazepam is one more important thing. This patient started throwing seizures, not seizures, but seizure-like activity on third day. So we had to give lorazepam to manage that. Coming to the last slide, of course, we should see that so young patients should not consume. I advised his father, though he is a farmer, to keep the pesticides away from the home. You keep it at your farm itself. So there are some. We should create some public awareness and also improve access to medical facilities in rural areas. Also, they should have given atropine in that place itself. It is very crucial to give atropine there. Otherwise, by the time they come here, they'll most of them will collapse. Third thing, of course, is prevention. See that the father doesn't store them at his home. So thank you so much. I hope you learned something from this video, and I hope I'll bring more videos discussing more about poisonings. Thank you so much.